Buenas tardes, bienvenidos todos. Muchas gracias por su asistencia a este acto que organiza FUNCAS y en el que tenemos el honor de recibir al profesor Ellis de la Universidad de Boston. Como saben, este es un acto en una serie de sesiones en las que queremos fundamentalmente desde FUNCAS contribuir a que la investigación que se realiza desde el punto de vista de las ciencias sociales y también de la epidemiología, de la gestión de servicios sanitarios, la salud pública, se pueda trasladar, se traslade, se comunique a los que tienen capacidad de decisión respecto del Sistema Nacional de Salud y también para estudiantes y el público en general. En las sesiones anteriores que iniciamos este año tuvimos una primera sesión dedicada a una muy interesante investigación que había sido dirigida y publicada como primera firmante por Beatriz González López Valcárcel, dedicada a la reforma del copago y a un estudio empírico sobre consecuencias de esta reforma. Y después, ya en este año 2018, tuvimos también una sesión muy interesante sobre los problemas de la cirugía de bypass coronario, una comparación entre esa intervención quirúrgica en hospitales españoles y en otros hospitales europeos, y tuvimos aquí una interesantísima presentación tanto de un epidemiólogo como de los propios cirujanos que participan en esas intervenciones. Y hoy, como he dicho, tenemos la suerte de poder contar con el profesor Ellis. Aprovechamos que él está pasando una estancia sabática en la Universidad Pompeu Fabra, a la que agradecemos también su colaboración. Y como digo, esto es una serie. Vamos a tener una última reunión en el mes de junio que se dedicará también a un trabajo de investigación muy interesante sobre eficiencia de los hospitales españoles. Yo, sin más, simplemente les quiero dar las gracias por su presencia. Les animo a seguir con nosotros en estas actividades. También, desde la última, está FUNCAS colgando en su web la grabación de la sesión. Lo vamos a hacer con algún retraso para primar a los que asisten, pero yo creo que era una pena que se perdiera lo que aquí se dice y se discute, y entonces va a estar disponible la grabación de la sesión también en las próximas semanas en la web de FUNCAS, donde ya empieza también a haber otros materiales sobre salud que se unen a los tradicionales de esta institución que, como saben, tanto contribuye a la investigación social y económica en nuestro país. Y ya sin más preámbulo, yo le cedo la palabra al profesor Manuel García Goñi, que es profesor de Economía de la Salud de la Universidad Complutense y que además es discípulo de Randall Ellis, porque Randall Ellis le dirigió la tesis doctoral, así que nadie mejor que él para presentarle. Así que muchas gracias, profesor Ellis, y gracias también, Manuel.
Gracias. Bueno, pues buenas tardes. Muchas gracias por invitarme a estar en esta mesa. Para mí es un auténtico placer estar en esta mesa y presentar al profesor Randall Ellis, Randy, que es desde luego un honor tenerle en España, como ya ha comentado también el profesor Lobo. Bueno, el currículum del profesor Ellis es impresionante. Es sin duda una de las personas clave del desarrollo del área de la economía de la salud a nivel mundial. Su doctorado es del MIT y lleva pues toda una vida en Boston University, en el departamento de economía de Boston University, donde, bueno, si miran sus publicaciones son realmente, realmente tremendas, no solo en la cantidad, sino en la calidad y en las revistas en las que ha publicado. Él, desde sus orígenes, trabajó en economía aplicada, no solo en la salud, sino que primero estuvo trabajando en otras áreas como medioambiental, por ejemplo, economía medioambiental, y después pasó a la salud ya en los 80, y desde entonces realmente su carrera es tremenda en cuanto a todo lo que ha producido. Realmente es impresionante. Además, yo creo que hay otra perspectiva, ¿no? Del trabajo que Randy ha desarrollado. Y es que no solo ha publicado muchísimo, sino que es que además ha conseguido becas y ayudas de numerosísimas instituciones internacionales, no solo a nivel americano, que desde lueguísimo lo ha hecho así, sino que también bueno, a nivel internacional. Y es una persona con presencia internacional en el área de economía de la salud, sin duda alguna. Pero no solo, yo creo que el currículum de Randy tiene 3 aristas que son fundamentales. Una, desde luego, y de la que he estado hablando hasta ahora, es la investigación. Como investigador es, desde luego, una auténtica figura a nivel internacional. Pero hay un aspecto que yo creo que también es muy interesante del profesor Ellis. Randy, en los años ya 80 y después ya en los 90, fue uno de los desarrolladores de uno de los sistemas de clasificación de pacientes más importantes del mundo, de los Diagnostic Groups. Y de hecho pues tomó parte de esa experiencia profesional y esa experiencia pues, empresarial y bueno, consecuencia de esto es que, por ejemplo, el CMS, el Center for Medicare and Medicaid Services, aprovechó ese sistema de clasificación de pacientes para para el reembolso del pago a los HMOs, a los Health Maintenance Organization, dentro del programa de Medicare y Medicaid. Entonces, esto es clave porque realmente esta arista es lo que hace que se una el mundo de la investigación con el mundo más práctico de la asistencia sanitaria. Entonces, realmente la transferencia de conocimiento entre la universidad y el mundo empresarial y el mundo, digamos, económico, la actividad económica, es algo que también el profesor Ellis ha hecho con auténtica maestría. De hecho, pues hasta hace muy poco tiempo ha seguido colaborando con esa empresa que después cambió de nombre y en la que ahora ya no tiene los mismos intereses que tuvo hace décadas. Pero es una persona clave porque fue uno de los grandes desarrolladores de estos sistemas de clasificación de pacientes a nivel internacional y a nivel mundial. Y bueno, no solo esas 2 aristas, es decir, el mundo académico real tiene que ver mucho con la investigación, tiene que ver con la transferencia de conocimiento, pero es que la tercera arista es que además Randy es un gran profesor. Yo he tenido la gran suerte de tenerle como profesor no solo en los cursos de economía de la salud a nivel de graduado, a nivel de doctorado, que me enseñó en Boston, sino que además ha sido mi director de tesis. Y bueno, yo quizás desde luego no soy su mejor estudiante con total seguridad, pero lo que sí puedo decir es que es una persona súper atenta, es una persona que escucha mucho, es una persona que además sabe transmitir el conocimiento de una manera increíble y que hace que las cosas que son tan complicadas y tan complejas realmente las entienda yo. Así que realmente es una persona que estoy convencido que nos va a dar una charla estupenda sobre cómo son los sistemas de pago. En Estados Unidos esto es un tema de importancia crucial porque el gasto sanitario en Estados Unidos es enorme, mucho más del que tenemos en España, y eso no quiere decir nada porque todo llega y nosotros también estamos creciendo mucho en gasto sanitario a pesar de las crisis y a pesar de todas las turbulencias que tenemos en España, y en cualquier caso es un tema de creciente interés y creciente preocupación. Así que yo no quiero entretenerles más porque lo bonito viene a partir de ahora cuando el profesor Ellis nos va a dar su presentación. Así que, de nuevo, agradeciendo la oportunidad y el honor de presentarle a Randy, les dejo con su ponencia que introducirá Félix.
Yours is the floor.
Well, thank you. That's very nice. The first thing is I have to get my slides up. It's an honor to be here. I enjoy having a chance to talk to different audiences, and as Manuel highlighted, I have spoken to groups all over the world. I'm going to talk today about health plan and health payments, and the particular issue is the question of how to pay doctors, hospitals, and pharmaceuticals as these important medical services. I'm assuming the microphone is working just fine, so if you can hear me, then it must be that the translator can hear me. And I have my own little timer here to try and keep track, so I'll be managing my time. You might reasonably ask, why are we listening to an American health economist, since you should know that the US does not particularly have a good healthcare system. We are both the most expensive and also not one of the most effective healthcare systems. But I will argue that that may be the reason why we have been studying payment systems and healthcare reforms longer than everyone else. And so maybe looking in the binoculars at where many problems will continue to be serious here, you might have something to learn from our mistakes as well as our efforts. I like to start with this slide that shows on the horizontal axis the time, and on the vertical axis the percent of gross domestic product that is spent on healthcare for a variety of countries around the world. And you'll notice that the United States is up there number one as the most expensive, spending the most on health care compared to any other country. And it's almost double what a lot of the OECD European countries are spending. And Spain is doing a much better job at controlling costs, at spending only about 9% of its income on healthcare versus the United States, which is now approaching 18%. And you'll notice a little bit of a leveling off soon after we implemented some reforms in the United States, but things have resurged and are looking bad again in terms of our controlling of costs. And I do like to point out that Spain is doing very well, but I also inserted Singapore down at the bottom of this figure. I guess it's not going to point much. And it's a reminder that there are some other high-income countries, including Singapore, which is a per capita income similar to the United States, actually, which is doing spectacularly in controlling costs through a lot of detailed reforms and trying to control, especially through demand-side policies. So there's certainly room for improving payment policy even in Spain. Another slide that I created just for my time here in Spain is this comparison of life expectancy. I apologize for the small font, but these is life expectancies for males and females. And number one in the world is Japan, and number two is Spain, with an average life expectancy of 83 years. Congratulations to you for being number two in one of the most important metrics that people look at. And I, too, am still trying to understand what it is that has made Spain so successful at that. You'll notice down near the bottom here, just below Chile and a little bit above the Czech Republic, that we have the United States at only 78.8 years of life expectancy. So we're about 4 years, or a little less than 4 years, below the Spanish achievement, and it points out some of the problems we have with our healthcare system in the United States. And before I get into payment formulas, I wanted to spend a little bit of time giving this overview of healthcare systems that I find helpful for motivating some of the issues that come up and why healthcare is different from other markets. So over on the left here, we see that in most goods, the consumer pays directly for the products and the services that they buy. So you go to the supermarket, you buy a car, you are negotiating with the seller. With insurance, there are two different ways that we sometimes think about insurance markets. One is that you buy insurance for a bad event. So a life insurance policy, you don't get any, it doesn't directly affect your consumption. You just buy a policy that will pay you if you were to get sick. That's called a reimbursement insurance. In the United States, automobile insurance works the same way, where you get in an accident and then you get an estimate on your car and they mail you a check that compensate you for your own losses and expense. That's to be compared with the one in the bottom left, which is for commercial insurance. We see that there's a three-way interaction where typically you pay a premium to a health plan. The health plan pays for your providers, the doctors and hospitals, and then the providers provide services to the consumers. So in this framework, the consumers may also be paying something additionally to the providers, which we would often call cost sharing or co-insurance. So this is another arrangement that is quite common, and it captures this idea of the separation of the health plan from the providers in the healthcare system. But the one that every modern developed country has is the one on the lower right here, which has 4 important agents in which you don't pay your money directly to any health plan or insurance company, but rather consumers have a sponsor. In Spain, the government is your sponsor because they collect money through taxes primarily. And then they transfer money to a different agent, which in most cases is a Ministry of Health for autonomous regions. So that's a separate entity. And then the health plan pays money to the doctors and hospitals, and then the doctors and hospitals interact with the consumers. So this is called sponsored health insurance. And it points out that we're quite different from most other goods and services because the money you pay mostly goes through your sponsor to a health plan, to your provider, and it separates your purchasing decisions of how many doctor's visits and how many hospitals days to receive from the choice of how expensive it is because of the way the payment flow works. So this slide is meant to capture the primary 4 agents for the bulk of the public system here in Spain, which is consumers pay taxes to the Ministry of Finance. The finance ministry has a way of allocating money to the Ministry of Health and Social Policy, and there's some regional allocations there. And then those entities are paying for the doctors and hospitals and nurses and pharmaceuticals. And finally, the consumers are there interacting with these 3. And I would suspect that here in Spain, as in almost every country, there are always debates between the finance ministry, who keeps saying, we don't want to spend as much on healthcare, and the Ministry of Health is saying, we want even more. So that is why it's important to realize there are 2 different agents here making this. In countries like the United States, the health plans are also very independent from the sponsors, who are either the government or your employer. But that creates some interesting conflicts and challenges to controlling costs. What I'm going to be talking about today are these 2 payment flows, the ways that doctors and hospitals receive money either directly from consumers or from the health plans or the payers, who are this group on the right. And even though it's a little bit overwhelming, I'm going to stick in these possible payment flows. There are 2 different flows to think about how you can make this arrangement. The consumers in many countries have different ways of making payments directly to the doctors and hospitals. In Spain, this route is not used very much other than the fees that are paid for pharmaceuticals. So this is not the dominant way that you pay for doctors, hospitals, or pharmaceuticals. But instead, the other way that you pay for healthcare is the payment flows from your health plans to the doctors and hospitals and pharmaceuticals. And there's a variety of different ways. And that's what I want to be talking about today. And I especially am going to be emphasizing that in addition to the usual ways of salaries or fee-for-service or sometimes capitation, there are ways of paying that may give better incentives to doctors and hospitals to do a good job. And I especially am a big fan of combination payments rather than extreme systems where instead of only paying fee-for-service or only paying salaries, you also try and have combinations that pay a little more for doing a good job. Because getting incentives right is a really important field in health economics. So I'm going to be talking about these 2 directions of payments, and I'm going to take advantage of several different papers that I'm going to synthesize in doing this. And I like to start with this somewhat humorous quote by a well-known economist in the United States, by Jamie Robinson. And he said, there are many mechanisms for paying physicians. Some are good and some are bad. And the worst are fee-for-service, capitation, and salary. And the reason this is kind of funny is because that's kind of like all of the ways. And I think that it's a reminder of two things. One, there is no perfect way of paying physicians. And two, maybe some combination of these things or something not included in that list is the best way of doing it. So it turns out that when you go on to read this same article by Jamie Robinson, I find as an economist a lot of really good insights in it. One problem with paying for each service, which is the dominant way it's done in the US and in quite a few other countries, Germany, Netherlands, Switzerland, many countries pay a fee for service, and it creates inappropriate attention to too many services. You want to do too much because doctors get more for each service that they're doing. And it also can create incentives for fraud where you pretend you did some service that you didn't actually do, or you exaggerate how complicated it was in order to increase your payment. Or another problem is even if the doctor is busy, they may do too many referrals to get services used by their friends and other possibly laboratories or hospital that they're affiliated with. Different problems arise with capitation in which if you have a fixed dollar amount per month that you receive for managing a patient, which is how primary care is paid for primarily in the United Kingdom, in England, then capitation for primary care payment can result in too much of an incentive to try and avoid having to do too much. And it could include, you especially don't like those really chronically sick patients who come in over and over again because you're only getting a fixed amount of money and they take up all of your time. Or a third problem, it may be that you choose to specialize your practice, and as soon as the patient looks too complicated, you refer them out to the diabetes specialist or some other provider instead of spending a little bit more time to avoid the need to go to that specialist. So those are the problems with a capitation formula. And then the third one, the salary approach, which I believe is very popular here in Spain. I'm still learning, but a lot of primary care providers are paid through a salary. And one criticism in other countries, I'm not so sure how serious this is here, is that it's often a charge that it leads to low productivity, that they don't do as much perhaps as the patients are expecting. It may lead to on-the-job leisure. This was a problem in the UK where it was hard to find a doctor on Friday afternoons because they were off playing golf or doing something else for their leisure time. And it may create this bureaucratic mentality in which the attitude is, this procedure is somebody else's problem, not mine. So that can be a problem for salary-based compensation. So this is sort of a background of what's sort of in the literature as some of the concerns. And now I want to talk about new ways of thinking about how you can use combination payment formulas that may be more rich than just these three polar cases. And so I'm going to also start, because I want to add a little bit, knowing that Spain is one of the users of a salary-based physician, I want to start with stories from two of my previous sabbaticals. I'm an old guy, and I'm very lucky that I've had 5 sabbaticals. I'm a huge fan of a sabbatical where they pay me every 7 years to go away for 6 months. And if you're a good behavior, you go away for a year at half salary. And some of you are saying, oh, I wish I had a job that let me do that. And I just want to tell you the good news that you can. It's called save 12% of your income for 7 years, and you will have saved up enough to pay yourself a salary for another year. And many of you are in jobs that really do give you the time of coming back and starting your job. So just arrange to teach more or to do your work in a different way. And you too could do what I'm doing, which is taking a lower salary than I could get as a consultant and enjoying my sabbatical times. So our first sabbatical, my wife is a development economist, we spent in Nairobi, Kenya. And at the time, Nairobi had a terrible healthcare system. And what was striking is even though they were spending very little money on doctors and hospitals, it was also very inefficient. There were a lot of ways that they weren't doing a good job, even at using their scarce resources. And the reason I knew that is we were working in the National Hospital, Kenyatta National Hospital in Nairobi, and I would arrive in the morning for this consulting project and research project, and we would see huge lines of people waiting outside to visit the clinics and the doctors. And then when we went out for lunch at 1 o'clock, I was always amazed that there was nobody left. They had seen them all in the morning. And I remember thinking, wow, that's amazing that they can see all those hundreds of patients early in the morning. And the answer was, well, no, the truth is the doctors only work in the morning, and then in the afternoon they go and work in their private practice somewhere else. And therefore, there's no reason to be waiting around because they're not at the hospital anymore. And I flagged that as a possible issue for Spain of whether your allocation of some of the time of your physicians, are you getting the full value out of their time? And my second sabbatical we spent in New Delhi, India. And in New Delhi, I had a former student who listened to this same anecdote about Nairobi and said the same thing happens in India. And he did something very brave. To me, I would never risk my life the way he did. But he visited doctors in their morning practice in the government hospitals. And then he asked the simple question, where do they practice their evening practice? And then he left the hospital and waited outside of their office. And he stayed there for a half an hour and counted how many patients went in and how many left. And he interviewed a few of them and asked them, how much did your doctor charge? And by doing that, he determined that the evening practices of these public doctors were more than 4 times their earnings as a public salaried physician. They were very profitable. And it was also a mechanism in that country for self-referrals, where you would see the patient in the morning and they would say, well, you're really more complicated than I can deal with right now, but you should come see me this evening, and then I can give you attention that you might want. And by the way, I'll charge the usual fee. So I'm only flagging that. I have no information about whether this type of story happens in Spain or whether you have a different kind of story, except to know it's useful to hear these and to think about whether the structure that has been set up is the best one. So fee-for-service reimbursement is not salaried physicians as they were in Nairobi or in New Delhi. But it is a system that is very popular, and it does get rid of this lack of interest in seeing more patients for your fixed salary or fixed capitation. But it's particularly bad for some of the new innovations that need to take place in healthcare, in particular the use of email and phone messages and texts, which I'm happy to hear is already a reality in Spain because it's vanishingly rare in the United States and in many other countries. Also team-based care, where you work with the nurses and doctors work very closely, and making good referrals and coordinated care. These are the kind of things that take significant effort, and fee-for-service doesn't reward those activities. So there's an under-provision of coordination and teamwork. Monitoring chronic illness, just checking in on patients, group meetings, end-of-life discussions, all of these are not well paid by fee-for-service. So thinking about ways to reward that is important. This is another slide with way too many numbers and facts, but basically this is the number for each of around 10 different procedures in the US. This is a brief description of the procedures, and this is the fee that doctors get for doing each one of them. To make it simpler, I abbreviated them with still too many words, but it lets me summarize that we have at the beginning is a brief visit that lasts 5 minutes. The doctor in the US gets $25. Or they could do an intermediate or simple visit. It's $44. They spend on average about 10 minutes. These are the guidelines of what a doctor should expect. An expanded visit, they have to do a patient's history, and they have a simple decision, 15 minutes. An intermediate visit or in a comprehensive, you can see the prices going up. So you can imagine then that the doctor is facing some scarce time, and they're trying to maximize their payment. They really like these longer, more well-paid services. So in fact, very, very few brief visits, even though there are sometimes that's all the patient really needs. And to think about the incentives then on doctors who are trying to pump up the intensity and length of their time for each visit is very counterproductive. And to show you how silly this might be, I have this slide that takes the same numbers and imagines that professors were paid the same way. And you can imagine that a brief office visit was, they only charge their students $25, or they meet with them for 10 minutes, it goes up to $44, and then finally they do the comprehensive 40-minute visit for their PhD students, and they charge them a much higher price. And then there's the short hallway consult for $13 and the dreaded reading the dissertation chapter that's way more time consuming than anything else shown. And so you can imagine trying to pay professors the same way we pay doctors, and this would be a very bad idea because it wouldn't free them up to make simpler choices about how to allocate their time. There would be perverse incentives to encourage students to get too many visits, and it would be a really silly way. So I think in the same way, paying fee-for-service only for healthcare is a bad idea, but maybe recognizing that some doctors and some professors work harder and longer, maybe they do deserve more compensation. So the ideas that are getting a lot of attention in the United States and here in Spain are organizing around patient care teams. In the United States, we're called patient-centered medical home, and ideas of organizational change to encourage team practice, better use of IT, bundled payment, which is the topic of today, as well as pay for performance, trying to measure performance and reward better outcomes. And it's, I think, a topic that I've seen a number of articles about here in Spain, and I'm very excited to see you trying to move ahead to further improve your quality of your healthcare system. And I think that comprehensive patient care teams could include two things that I've also been a fan of. One that Manuel alluded to is a risk-adjusted model of payment, in this case, a bundled payment just to cover the services for primary care physicians. And you could try to do that either on a per month or per quarter system, which is how I would happen to prefer, or a per episode framework. It emphasizes population management rather than just paying for each visit. And you could try to reward them for enrolling high-cost, chronically ill people by paying much larger amounts. So the concept of risk adjustment is one that tries to quantify the relative difficulty of managing different kinds of patients. And the population-based is really trying to focus on their illness rather than what was done to them. So once you start paying for the procedures, you're going to always reward more volume. And then the separate component is to also risk adjust the performance measures. And this is maybe a newer idea that when you're paying for the doctors to do a better job, you also want to have quantitative measures of how well they're doing and give them more money, if you will, or at least better report cards for how they're doing. And this slide also has way too many words on it, but it's partly an excuse for me to point out that in the US, the Medicare program has become very much a fan of using detailed performance-based metrics. There's a link here that probably will be hard to read on the bottom, but it's showing that in addition to measuring things like how many lab tests did they do and how many visits, there's also, see, even I'm having trouble here, they have patient survey measures that include things like did they help improve the person's mental health or improve their physical health. So these are survey-based measures. Or how well are they controlling the high blood pressure of a person with hypertension, or diabetics, how well are they controlling their cholesterol and their blood sugar. So there are specific measures that are looking at some intermediate and actual final outcomes. And then finally, there's a whole list of measures that are for how happy is the patient. Did you feel they were coordinating your care? Did you get follow-up care? Is the customer service good? This is pretty different from just focusing on clinical quality. And I think there's a tendency to focus just on clinical quality measures, but this is highlighting you can also measure consumer satisfaction and quality. They're more likely to come back and get their next care if they're happy with the care they just received. So now I'm going to move to a different framework for how to decide on the weights and to characterize different healthcare systems. This is a paper that came out in an encyclopedia of health economics with two former BU, one current and one former BU PhD students. And the basic idea here is to think about the supply side incentives, how you pay the doctors in hospital from the Ministry of Health or in the US from the various health plans. And it's an extension of the early Ellis and McGuire paper that I'm perhaps best known for, which I'll talk about a little bit later in this talk. And there are really 4 dimensions to think about when choosing a payment system, and I think this paper does a better job at organizing those different ways. The usual way people talk about payment systems is to just think of maybe 6 things and try to put them on one dimension, with fee-for-service being the more detail-oriented way, and then full capitation and salary being the most aggregate. But the problem with these is that they're really too simple. They don't have enough detail, and salaries doesn't really fit in here, and bundled budgets, budgetary systems for hospitals. And it also says nothing about whether you should have a lot of categories or a little. And it doesn't even tell you what information you would use to calculate payments. So this is the area that I've spent a lot of time thinking about, is that the types of information. And the key thing is that you can think about information. I'll get into more detail in this. The type of information describes the payment system, how much you're going to bundle or include groups of services in a payment category. Are you going to have a lot of different groups or only a few? And finally, are you going to be generous or stingy? High payments or low payments? These are the 4 broad areas. And one innovation of this paper, I wanted to insert this to say, and the direction you should be trying to go, so I'm being proactive here, is to encourage patient measures like reward for how well the patient is doing, use ex post information if you can, and then use broad breadth, fine categories, and try to be not so generous. I know the last one, some of you are probably doctors and providers. I know that sounds cruel, but the problem in the US is prices are too high. Now, maybe that isn't the central issue here in Spain, but that is a major reason why we have such over-provision and too high an intensity of care and inappropriate care in the US. So this is a new idea that probably most of you won't have seen, is when thinking about how you pay providers, we have these 3 dimensions. There's attributes of the provider, attributes of what they did to the patient, and attributes of the patient. So you can think of this by whom, to whom, and what. And you get to choose. Are we going to pay on the what, or on the by whom, or the to whom? Now, before I start, which of them is Spain using for primary care, for instance? Mostly, I believe, they're using salary to the physician, and the salary rate is probably mostly determined on the experience and age and the ability of that provider. Maybe it also is somehow based on their volume of patients, which would be reflecting their services. But I'm just pointing out that there can be these attributes. And as I did before, this is this duplicate. So now one other extreme is to pay on pure capitation, where you look at what kinds of patients the doctor is seeing, and you try to reward them for taking a sicker patient by giving them more. And so both pure capitation and a pure diagnosis-related groups, or DRG system, is looking at how sick is the patient and giving more money for taking care of sick patients. Another possibility is, let me actually go to this one over here, pure fee-for-service just looks on what did you do. I don't care how sick the patient is, how many lab tests did you do, how many visits did you do, what kinds of volume of activity. That would be a pure fee-for-service. The approach that I've advocated with Tom McGuire is this mixed payment system that pays partly on what's the illness burden of the patient and what is the fee-for-service of the actual services done. So maybe a 50-50 split is a very useful measure of these two. Those are not the only ones, though. Salary is a very popular one in the US and previously in the UK. Another possibility is something even in the middle. In the United States, our diagnosis-related groups, the actual DRGs, are kind of a combination. They pay some attention to where were you treated, some attention to what was done, and lots of attention to the characteristics of the patient. So you can calculate payments that reflect all three components. And finally, wages are another way that's not quite the same as salary, but the amount of time you spend in giving services is reflected a little bit in wages, but it's not just based on your credentials. Now, interestingly, professors are down here mostly getting salary, but it's performance related, at least in the United States, where more productive professors in research and teaching are generally rewarded with higher salaries. So that would move it towards the direction of service and patient achievement, perhaps, or papers and achievements. So I think that all of these are the information used. Now I'm going to talk a little bit about how much do you want to bundle? How big a bundle of services are you going to be using? And you can either imagine a relatively narrow bundle where you only pay for what the doctor's doing themselves, or a broad bundle that includes the lab tests that they recommend, or maybe even the specialists that they refer to. So you could have doctors being paid only for their own time, or you could include all the lab tests that they have to give, or you could even have them bear responsibility for every time they refer to some other specialist that is going to cost them something. That's an example of a pay-for-performance kind of metric. Another idea is hospitals. In the United States, the diagnosis-related group, the DRG payment, only pays for the room and board and the nursing time. It doesn't cover even the surgeon or the physician. But in Germany and in France and in many countries, it also includes the physician time. And more controversial is whether you include things like the follow-up care to the hospital. So do you want to make the hospital responsible for making sure you receive necessary follow-up care? That would be an example of this very broad approach. And you'll see that I'm going to cleverly combine all of these four dimensions on one figure. So I have to create the little notation and technique for that. So the amount to which you fill in the shape is going to be a sense of how broad it is. The more filled in the shape is, the broader it is. Okay? So we have very little filling in and a lot of filling in. Now we get to how many categories are you going to want to have. You could either have only a few categories, or you could have a lot of them. And it's interesting looking across the world. Some countries don't use DRGs or have very few. The US is now up well over 800 of them. Or prices per office visit paid by the health plan. In France, they basically have one fee. Lots of primary care, one fee. Doesn't matter whether it's 5 minutes or 20 minutes. You get one fee for each visit. In other countries like the US, you just saw we have a very fine system with lots and lots of categories. So each dimension, are you going to pay one price for each MRI, or are you going to have different prices for every body part they do, or every type of MRI, or every type of X-ray they do? You get to choose how fine you want the payment system to be. And I'm going to use the number of points on the shape to represent how fine. So the pointier it is, the more fine the system is. And a coarse system is round. And then we get to, just as an example of fineness, in the United States, we just implemented the ICD-10 diagnostic categories and procedure codes. And the big shocker is that both on diagnoses and on procedure codes, there's a huge proliferation in the number of codes. It's really kind of sad. In the previous ICD-9, there were 14,000 codes. The new system has just under 70,000 diagnoses. And then in the ICD-10 that WHO is using and Spain is using, there's not that big a difference. It's still only around 15,000 codes. So good for you. I don't happen to like 70,000. It's too many. And same on the procedure codes. There's so many procedure codes now that it's going to be easy for the providers to have confusion and maybe less clarity on that. And again, the WHO has a much simplified provider code system. And finally, generosity, which you can think of as how, in every payment system, if you pay doctors or hospitals or laboratories or pharmacies more, they will provide more. You know, that's just the way they behave. But it's true that fee-for-service really makes it even more responsive to generosity. When you increase somebody's salary, they don't necessarily work that much harder, but if you make them get more for every time they see a patient or every time they get an office visit, then they're more eager to do more of that activity. So your choice of payment system is particularly matters the generosity in the fee-for-service framework relative to the bundled or salaried or capitation systems. And so I'm going to represent generosity just by the size of the shape. So now I don't know if this is worth the build-up, but one way of thinking about it is the United States used to be mostly fee-for-service and is moving towards bundled payment, trying to use more patient care. And much of the rest of the world was using more salaried and budgeted systems and is also trying to move towards more bundled payment. And now to combine that in a more useful way, I could characterize, and I had Spain on here before I visited Spain. Maybe I would revise it slightly, but the US is an incredibly generous, incredibly fine, moving in the direction of bundled payment. Singapore is largely fee-for-service, incredibly stingy, very simple, like not many categories. So you capture that element. And Spain is sort of like in between a medium number of categories, lots more generous than Singapore, but still on the stingier side on the world spectrum, and working towards bundling because of the way they're using salaried and budgeted systems. So it's a little more bundled than the US. And so you can think about this both in physician payment, is what I've kind of been looking at so far, and then you can also think about trends in hospital payment. And so this kind of is a useful framework. I haven't gotten around or had a graduate student who wanted to try and look at 20 different countries and see where you would try to plot them, but it could be interesting to track them over time as a useful framework for thinking about this. But it's way more complicated than just saying salaried or fee-for-service, because a lot of countries are using some mixtures of different kinds of payment systems, and that's a good thing. And so the general trends have been towards increased use of patient information, more bundling, and finer, more categories, if you will. Although not every country is the same. Germany has been trying to simplify their payment system. Most countries are moving towards more general, but not always. They might not want to. And finally, there are examples around the world of countries using a mixed payment system, partly fee-for-service and partly capitation or salary. And it creates a really interesting incentive, especially my favorite is Denmark. They have a capitated system for your primary care doctor. They get a certain amount that's based on how many patients they see and how sick they are. And when your patient goes to a different primary care doctor, the system says, well, Dr. Jones, we see that one of your patients went to see Dr. Smith. We're going to reduce your fee a little bit because we have to pay that money to the other doctor. So it actually is a good way of getting the primary care doctors to want to corral and keep access to their own patients, rather than just leaving a free-for-all like the United States, where we sometimes call it ping-pong treatment. A patient can go and see many different providers until they find the one that tells them what they want to hear, perhaps, or that gives them whatever they need. So I have one more story, which is that just because I am describing something that you might prefer doesn't mean it's easy to do it. And this one is not from my own sabbatical. This is from a former student who was working in Nigeria on a research or consulting project, helping to advise them and study what happened. They had the same problem as Kenya, in which the doctors were paid a salary by the government, but they spent a lot of their effort on private practice. And so they decided to make a one-time offer to the doctors and said, look, doctors, we want to force you to decide, are you a public doctor or a private doctor? If you agree to work in the public sector, then we're going to double your salary, but you can't work in the private sector. Or if you want, you can just give up your public salary and go work in the private sector. And so there are two questions. First, what happened when they implemented this system? The first question is, what do you think happened? How many people how many of you think that they went for everyone went for the public sector? Okay, how many think they all went to the private sector? Okay, a few more people. Okay, so the interesting news is almost every doctor signed up for the public sector. Okay. The second question is, what do you think happened after everybody signed up for the public sector? Did the private sector suddenly disappear? No, because there was no new enforcement mechanism. They weren't supposed to be working in the private sector anyway. So the point is that merely announcing you're going to change that, they were all happy to take the doubling of their public salary, and then they kept doing the same illegal kinds of secondary market. So it's a reminder that sometimes it's not always easy to do that. Okay, so this leads me to my favorite paper, and I have to talk about this. I think the reason that it's so popular is that I wasn't like most economists who just assume doctors and hospitals are greedy profit maximizers, but it allowed for the possibility that doctors are somewhat altruistic. And so in this framework, I want you to think about the spectrum going from being only focused on profits to only focusing on helping people. And to think of, can any of you think of an occupation of what you would put of somebody who is only about maximizing profits? One volunteer. Finance, okay, good. Anything else? Okay, that's good. I often like to put used car salesmen over there because I don't think they're out there to help people, they're out to sell cars. Nothing wrong with that. What about an occupation at the other end? Non-profits. I'd like to put school teachers. So here's some examples. I put Branks. I don't hold it against them. They're there to make money. And then I put at the other end saints. And I put professors somewhere in between. They do care about helping people and benefiting. And then the car salesman. Doctors are somewhere in the middle. And school teachers are on the right. And then maybe tourist shops, you know, they're in it for the money. And charity workers, social workers. So I think we have a same sense. And what point is, I would personally put professors and doctors somewhere in the middle. They are motivated by money, but they also are there partly because they're altruistic. So we characterize the degree of altruism by alpha, the fraction of the weight they attach in their happiness function to this. And so here's a little simple model where we take about the happiness of providers that depends on their profits and how much they get utility out of helping their patients. And so you can then model the profit function as having a lump sum amount. This is the capitation amount, as well as a per capita, a per visit fee, like a fee for service. R and C is the marginal cost of each of those services. And then here's the happiness they get. So Q is the quantity of care, or if you want the quality of care, the same kind of thing. And so you have these two payment parameters. I'm going to go quickly over this. Either this makes a lot of sense to you or it's a lot of math. If it's a lot of math to you, then that's fine. You don't need to follow this. But the interesting thing is that usually economists like to emphasize that you should have the marginal benefit equal to the marginal cost, or B sub Q, the marginal benefit equal to C, the marginal cost. And it turns out in this simple model where you only see one doctor and you're attached to the doctor and you follow their advice, then you can implement the first best and achieve this marginal benefit equal to marginal cost by paying them an amount that's a fraction of their marginal cost. So don't pay only fee for service. Pay, let's say if alpha is 1/2, they attach half as much weight to benefits as profits, then the right strategy is pay half of their cost, fee for service, and half of it in a lump sum way. And so that's essentially this mixed system that we've had. Now the problem with this is that it makes a lot of simplifying assumptions. And I've spent much of my career trying to fill in these weaknesses. And I don't have time really. We worried about adding in demand side cost sharing. We worried about adding in heterogeneity. And we worried some about the competition. And then there's this little loose end of, well, what about if there are all these referral services and pharmaceuticals that we could have a problem with additional pay for performance incentives? And so that's what this little segment does. And I want to warn you that I'm going to use a little more math. So if you thought that was a scary amount, now I'm going to actually use a tiny, tiny bit of math just for a couple of minutes here. I know time is precious. And so we go back to the same framework where we have profits to the doctor, say, and now we have also benefits, but we have two parts. There's the benefits from the doctor's own treatment, and then there's the benefits from either the specialist they refer to or the pharmacy expenditures. And so the interesting thing is that the doctor only gets paid for their own time, but they're telling you what to get for drugs or for specialty care. And the key thing is they might want to help you, they value those benefits to you, but they don't have to bear any of the costs. Right? So in this case, what happens is the providers only provide Q1, not Q2, and so they have an incentive to over-recommend Q2 because they don't bear any cost for it. And as a result, what you get is, now that's just slightly more notation, what you could have the possibility they might attach not as much weight to the benefit from other people's care. We allow that in this version. And so clearly, if the physician cares about these benefits but doesn't bear any cost, they're going to be over-recommending Q2. That's the only point of this simple example. And so when you do the mathematics, I just presented the solution, you end up with, oh, look at that. It's interesting that the pointer does not work on this screen. But anyway, it does work. It's just, so you get the usual result for their own services, and then you get this interesting result that they have to pay a penalty. They have to tax them something when they overuse these services. And especially when they use more than the expected amount. So the formula gives them a lump sum equal to their expected amount, and then punishes them when they use more than that amount. So the way you sell this to doctors, because patients and doctors don't really like this, is you say, well, we're just implementing a pay-for-performance system, and we're going to give you lots of extra money to care for some of these other services. But then if you have a higher than desirable rate of laboratory tests or inpatient readmissions, then we're going to lower your performance payment. Right? That's kind of what pay-for-performance does, and this is sort of a model that implements or suggests how you would want to do that. Now, this is the last paper I wanted to talk briefly about. It just came out in the Journal of Health Economics, and it involved massive amounts of data analysis. And I could have spent all my time talking about this one paper, because I think it's really cool, even though I'm just going to touch on it now. So we go back to our 4 agents, same picture as before. And now we ask, I'm going to be looking, all my rest of my talk has been on this payment flow. Now I'm going to talk a little bit on what do we expect consumers to pay for their health care. Are we going to make it free for everything, or are we going to charge some fraction? And in most of the United States, we pay a fee for service, and there's a fee per item that's a fraction of the total amount. So it's called co-insurance, where you might typically spend 5 or 10% or 20% of the total cost would be charged to the consumer. So the interesting question is, how much does that actually lower your use of healthcare services? In Spain, you have a co-insurance or co-payment on a lot of pharmaceuticals, and the interesting question is, how much does that reduce the use of certain pharmaceuticals? And so we were interested in that question. That's called the elasticity of demand, which quantifies how much does the quantity change for a given change in price. And this paper that we just finished took advantage of an idea that has been there for some time, but no one else seems to have realized, which is when you have a high deductible plan, then people face higher marginal prices at the beginning of the year than at the end of the year. What is a high deductible plan? The plan I'm in now, I have to pay the first $3,000 out of pocket before I get any insurance. And then eventually, if I keep spending money, I get 20% of those costs. And then eventually, when it adds up to a number around $5,000 for my family, then everything becomes free. So I have quite a bit of incentive until I exceed that large deductible of $3,000. The things cost me a lot out of pocket. And the interesting question is that within this, some people know they're going to exceed it, and then they quickly do and react to the lower price. Other people don't expect to exceed that and act as if prices are high. And so because of this, there will be some services that you consume before your deductible goes down, or you spend your deductible on some that are later. And so there are a number of results that we get by looking at this. We can look at spending on children, and spending on how people respond. So the good thing about this paper is I can show our technique graphically. It takes very little little time, so I can go right through it. So this is the cost-sharing fractions during the year for health maintenance organizations. They're a very popular structure of health plans in which they try to emphasize prevention more, and they actually receive a fixed capitation, and they're at risk for any spending. And the thing that's mostly noticeable is that everything is flat, that the copayment is constant during the year because they don't have any deductible. They just charge a fixed fee for each visit. There's a little bit of an interesting little tweak here, which is related to when medical students first start working over the summer, but that's a little side distraction from the main point. Okay, so think of the prices are constant during the year, and as a result, use of services is constant during the year. Okay, no real surprise, almost horizontal. Now we look at the other type of system, these high deductible ones, like the one I'm in. If you do the same cost sharing, you see that people have to pay a lot of money for healthcare at the beginning of the year, and only when they exceed the deductible, eventually the prices get lower. But as a result of it, it's predictable that a high fraction of people are paying a lot at the beginning of the year and little at the end. And it turns out that if you then look at spending in these same health plans, they're actually using a lot more care at the end of the year. I believe if this became the dominant way of insurance in the US, doctors would be just too busy by the end of the year, the specialists in particular. And also pharmaceuticals we see are growing the most because they're the most responsive to the healthcare. So this is a figure where I apologize again that the fonts are a little small, but it's pointing out the usual result that office-based care is much more responsive than inpatient care, and that pharmaceutical spending is also more responsive to prices. So these are still pretty inelastic. So pharmaceuticals is minus 0.44, but it's the most responsive. So good for Spain that you've chosen to put cost share on the most demand responsive service, because that's what optimal insurance would suggest. And I have a separate paper on that topic. But it's also interesting that some things like prevention or dialysis, home visits, and surgical procedures don't respond to cost sharing. So it would be foolish to try and tax people on them by cost sharing. So it actually it captures pretty well the types of services to get the highest cost sharing in the United States. And you can also do this by, these are for different classes of services by age, and we find that young people, children, people don't change their amount for children. They are just do what they want to do regardless of the cost sharing. So it would be better to just fully insure children. And it's the middle age group that is the most responsive to insurance, and older people. And then also you can do, there are other parts of the paper as well. And so I wanted to just give you 3 references. So now they'll be in the slides, so you can pause this if you wanted to track this down. They're also posted on my website if you look for my name, and you'll be able to find my research articles. And that is the end of my presentation, and I'm very happy to answer questions.
Muchas gracias al profesor Ellis. Ahora efectivamente tenemos algo de tiempo para las preguntas que puedan plantear. Matilde Machado, profesora de la Universidad Carlos III.
Hi, Randy. Thanks for your very interesting talk. I really appreciate it. I'm going to ask for a few of the slides to use in my own classes. I had a question. You didn't focus too much on this issue, so if you want to leave it towards the end, that's okay, or we can talk later if you like. It was the pay for performance that you mentioned, although you didn't focus on it. My recollection is that, for example, research on report cards in the US, Dranov and et al. Famous paper, long and famous paper, seems to give sort of a very I mean, not very enthusiastic view of that sort of mechanism, like the report cards, right? Mm-hmm. The experience that New York and Pennsylvania had with report cards. So I was wondering if you could comment on that, whether we moved forward, whether report cards have improved, whether the danger of selection of patients that Dranov and co-authors mentioned is still there, or whether it's something that is there in the future. Thank you.
I think that's a very good question from another former student, so I have to thank her for that. But I think the Dranov results, which were very early, were a little special in that, in their case, they found some surgeons were avoiding the sickest people because they didn't want to get a bad report card for how many of them were going to die or be readmitted or become complicated. And that is a problem with it. I will say that I believe the report cards have gotten better since that first study was done quite a long time ago. And so that ideally what you would want is to risk adjust the outcomes so that you wouldn't just look at mortality and readmissions and complexity, but rather, were they worse than expected? So it would be okay to have a high mortality rate as long as it's a really good severity adjusted mortality. And that's what the better hospital performance measures, they try to do a better job at adjusting for severity of the people who are at risk. Because if they did that, then ideally the doctors and hospitals would not worry as much about getting a bad report card. But I do agree with her that in some ways, my enthusiasm for pay for performance has changed towards the value of public reporting of performance, which is not the same thing. That for many physicians and hospitals, you don't actually have to tax them for doing a bad job. You just have to tell the world and their colleagues and friends and other people that they're doing a bad job, and that may be sufficient reason to change. So for instance, doctors who are wonderful people also have very big egos. They hate being told that they're doing worse than many of their colleagues, and they may feel motivated to try and improve just for that knowledge that their colleagues can detect or see their bad experience. And in some measures, like the use of lab tests or referrals, they don't necessarily even realize that they are abusing that. They're doing too many referrals and too many lab tests. And so merely telling them, did you know you're using 40% more, may help give them a reason to reduce the overuse of some of those procedures. The other danger, though, and this is a tough one still, is that the lowest performers, usually the hospitals are the ones I'm most familiar with, they often, if you start punishing them by giving them less money because they're doing a bad job, they need the money to improve. So maybe they need better training of staff, or maybe they need some new facilities. And if you just keep punishing them for doing a bad job, how are they ever going to improve? That is one of the big challenges. And so if you were to look at the fine print on my huge quality report card that I had up on the screen, which is what is being used for Medicare, they are trying to move towards rewarding improvements in those measures rather than just the levels. And that is really a much bigger challenge, because now you have to risk adjust the improvements, not just the levels. But I do like that direction of thinking of changes rather than levels.
So I got one question related to the previous slides. So in one of the slides, you list of all the pretty much like the payment for each doctor in different category, but the basic one is the 5 minutes visit, which is I forgot, like $25 or whatever. But I measured it by minutes. But if you see it this way, it seems like if you do a short time visit, it's actually more profitable than a long term, like a 40 minutes visit, because per minute, it's even, the margin is higher. So, but at the same time, you also said the doctor tend to pay more attention for the longer visit, which decreased the accessibility for the general visit. So it's more like a controversy to me. And also at the same time, U.S. has lower life expectancy, but they have a better progress on the chromatic, like I forgot how to say that word, but
Chronic disease?
Yes, yeah. Chronic disease. But so that means they have like a lower accessibility to the general hospital, to like a lower income people, which is affordable care, trying trying to input. But do you think if they change the format of how they pay the doctor or physician, can it be like push the doctor or physicians to go towards to expand their accessibility to the lower income people rather than pay more attention than higher research or much better, much like costly research?
Great. I think you asked at least 3 questions or made 3 comments. So let me just try to answer each of them. Okay. I realized that only partway through I need to write notes. The first one was that to understand the structure of fees in the US, and what almost everybody forgets is that for every 10 minutes or 5 minutes they spend visiting a patient, they also have to fill out informational forms when you leave. So the 5-minute visit actually takes more than 5 minutes, probably takes 10 minutes, because the doctor has to either dictate or write down notes about the visit, make sure you get the referrals, and so there's a paperwork component that's not captured by the time they're actually meeting with you. And so I've looked at the rates of these, and I know that the brief visits in the US have almost disappeared entirely. Now, the second comment on that is that actually nobody is standing there with a clock watch keeping track of your time with each patient. So what matters is what the doctor ticks off at the end is like, oh, this was an intermediate visit because I did these medical complexity issues, not how long it is. So the minutes don't correspond. There are separate studies that look at that. The second question you mentioned is about chronic care, and it's a much bigger topic. This talk is not about why is the U.S. so bad or better than the rest. Some of the studies show the U.S. is better for the elderly than for some other countries, and I think that's an interesting point. And it's also true that the U.S. does somewhat better in measures of quality of care rather than, life expectancy. So life expectancy is a very blunt tool, but not as so many that in general the Commonwealth Fund repeatedly has found that the U.S. is only a mediocre to poor rated system, and most of the reason for that is because the U.S. has very poor quality of care for the 17% or now 10% of the population who has no insurance. So these are really not well-insured people who are not getting enough prenatal care and primary care and are relying on emergency department care. And I will say that the group that's somewhat similar to that in Spain are the people who are illegal immigrants or undocumented workers who are also vulnerable to too little care. And it matters a great deal. And since you raised it, or I'm going to raise it, Singapore, one of their secrets that they don't like to talk about on their website for their low cost and their very high success rate is they do not include the 35% of their population who are non-citizen residents in their calculations. So if somebody wants to do a really interesting paper, you could try and track down their health status and how they would change the picture. If the US could just drop all of our Medicaid enrollees, i.e. the poor and the uninsured, way less than 35%, we would have the world's best healthcare system. So I'm just trying to say that, there you can, distort. And the last thing about the ACA, yes, the ACA is doing a lot of stuff. I'm not sure I could really summarize that. I've already talked too much. Mm-hmm.
Hola, soy Lola Rubio, soy la directora del Hospital Dr. Rodríguez Lafora. Voy a preguntarle en español porque creo que así nos... Quería, en primer lugar, felicitar por su exposición, súper interesante, porque además en poco tiempo ha intentado hacer una síntesis, ¿no?, un poco de las diferentes variables que debemos tener en cuenta a la hora del tema, ¿no? Creo que el sistema perfecto no existe, sino que estamos ahí en los sistemas mixtos, ¿no? Los defectos que ha dicho usted de que tiene el pago, uno que genera más actividad y otro que genera menos actividad, ¿no? Pero yo quería que dentro de esto nos sitúe un poco de cara adelante, hacia el futuro, en cuanto a que estamos iniciando una nueva era en cuanto a la asistencia sanitaria, ¿no? Lo que es la apuesta por la medicina de precisión o la medicina personalizada, en donde creo que el presidente Obama inició un estudio muy interesante en cuanto a ver, ¿no? Este nuevo futuro, ¿no? Entonces querría ver un poco cómo ve usted que debería ser el sistema en ese marco del Big Data, de la medicina de precisión. ¿Cómo cree usted que debería enfocarse? ¿Hacia dónde deberían caminar los sistemas sanitarios?
Thank you for that question. That's an interesting one. I'm working on a paper that will be done in the next few months and presenting it in Barcelona in a few weeks and in Pamplona also. But I think you're right that we are aiming towards a different world with innovations, especially in cost-increasing customized medicine. And the truth is, as an economist who worries about costs, I'm really worried because they're really going to be expensive, and I have to believe they'll all be patentable, i.e. outrageously expensive, and therefore they will be priced at people's willingness to pay. And they won't price it at your willingness to pay. They'll price it so that your share of whatever your copayment is makes you willing to pay, with the health plan or the Ministry of Health paying the other 90%. And that is a scary big number. So if I were a country with a lower cost healthcare system like yours, I would say, great, we look forward to cost saving innovations, but I would be really frightened by the biological and the robotic medicine and the new types of care that are being developed, that they could be very expensive. And I do think there's some room for, big breakthroughs in quality, but it's still all hypothetical right now. So I don't know. We'll see. I don't know if that answers. You may not want that. I'm a little bit gloomy on that. I think we have to change the way we regulate and encourage innovations, because so far a lot of the emphasis has been on really expensive things. I'm a big fan of all the attachments to your iPhone that turn it into a little health register that measures your heartbeat, and they can do your heat sensing to detect cancers and all kinds of really low-cost technologies. Or the simplified neonatal incubator is way less expensive than the $10,000 ones. They can be made for $500. And the question is, why aren't we seeing those lower cost innovations that could replace the expensive ones that we have?
Sí, José Ramón Repullo, de la Escuela Nacional de Sanidad. I think that the doctor's behavior is quite difficult to understand. Because of that, we need to look at the natural experiments. And in Europe, we have a very interesting experiment in the GP's payment system in the United Kingdom. It is a quality and outcome framework. And many of the assessments have not been very positive. A lot of money have get into the system,
Yes.
and it's not clear what have we get out of that.
Yes.
What is your opinion about that, please?
So you said we've had a lot of natural experiments. I want to encourage more randomized experiments, which are not just natural experiments. Every time you're implementing a policy reform and you have a finite budget, then think about the simple ways that you could choose one set of providers or one region or one type of, the first half of the alphabet, if you want, to give this innovation, and then look at how much better or worse it does compared to your control group. So that is a huge emphasis all around the world in not just natural experiments, but somewhat randomized or controlled experiments that don't have to be that expensive. Now, you're exactly right in the reforms that were first done in the UK that were quite a while ago. They were now in the 1990s or early 2000s. They wasted a lot of money by rewarding doctors for really stupid things. So doctors could get extra bonuses for recording how many asthma patients they had, or recording how many diabetic patients. Well, they already knew who they were. They just weren't putting them on the information given to the National Health Service. So they ended up paying money for doctors to just write down information on a report card or a form that they already knew. And they ended up overspending all of their bonus payments They spent all their incentive funds like in the first year. It was too easy to achieve the targets. So it was a poorly designed, early implemented system. I wrote one paper about it, and there were others who wrote more critical papers. And I do think that that's an example of a better, smaller scale experiment before they had done the big thing would have been the right way to go.
¿Más preguntas?
Thank you very much for your presentation, Randy. It was wonderful to see one other class from you. So a very complete class, by the way, with all the systems and the different schemes in different countries. Well, there is one comment on one of the topics that we already talked earlier with Matilda's question. So she was asking about the pay-for-performance system. In the pharmaceutical industry, there is the risk-sharing agreements that have been quite famous also in the last years. Well, not famous because we don't have much information about those, but actually they are kind of the same. I mean, the philosophy is basically the same in terms of whether we should be paying more or less depending on the proportion of patients that are getting cured or they get better results in terms of their health status. That's another tool that has been used basically in order to contain costs for the very innovative and very good drugs that are now in the market. But at the same time, we have the same problem of transparency of the results because there are no, basically, those contracts usually are private information and it's quite difficult to know how to deal with them. Exactly the same as the transparency of the quality measures that you mentioned in your slides, and that many times the question is, okay, so transparency is going to be very, very important on the one hand in order to be able to transfer all the benefits of that policy, but at the same time, in order to have the benefits, in order to get the benefits of the transparency and the pay for performance and the risk-sharing agreements, you also need to be able to choose. So basically, you need to link in the system the how to choose between the different providers, in a sense, and the transparency of the results for those providers. And that's not that easy to do or to implement in the different healthcare systems. So do you have a comment on that? And maybe how you are doing something like that in the Medicare, for example, that you have all these implementations?
I'm not sure I can answer this. It's a very big question that you're asking. Is this more than just a payment issue? I think that you're right. There are some interesting innovations of trying to figure out which drugs are more effective and then allow higher prices for those. I'm not aware of that approach being used in the US. I mean, there may have been experiments, but I have not followed any literature on that. I am aware of the very avid group that are recommended towards what's called value-based payment, in which they find the lowest cost or the highest quality doctors and hospitals, and health plans try to channel their patients to those health plans. And that's also been done in some European countries, such as in the Netherlands. But here's the challenge. There are only certain many hospitals around, and there's only certain many good surgeons. So if one health plan channels their patients towards the better surgeons or hospitals, it doesn't necessarily mean that the other lower quality or higher price hospitals are going to change their quality or lower their prices. Maybe other people will just say, oh, I can finally get an appointment for my knee replacement with this other hospital that's not as busy anymore, right? So you have to be careful that the private benefit is benefit to an individual health plan to do that, but it might not correspond to a social benefit. So in the case of Spain, where you have a national system, I don't know that channeling patients towards the better hospitals or doctors is necessarily a great approach, given that that hasn't been the approach you've chosen. You know, you aren't into the networks of provider choice framework. So maybe that's a big change for Spain. It's not obvious that that would be a good one. I am a fan of having advanced guidelines for pharmaceuticals, where you would say, we don't think any drug that doesn't save your life but just makes you better able to enjoy tennis or soccer is worth $50,000 a year. Because there are drugs on the market in the US that are allowing a colleague that I know to play squash at age 65, and it costs $50,000 a year. Well, that's a pretty high price tag for being able to play squash, right? So I would say if he wants it, fine, let him pay for that drug. That's something society shouldn't necessarily pay. And that is the challenge of what to do about these effective but very expensive drugs that are now starting to take over. And the biologicals are the future. There's going to be a huge growth in that.
Si no hay más preguntas, voy a formular yo una muy general, lo voy a decir en español porque están traduciendo. Le hemos oído al profesor Ellis decir que en España lo estamos haciendo muy bien porque nuestro nivel de gasto agregado en sanidad es una proporción relativamente baja del Producto Interior Bruto. Sin embargo, si usted oye lo que se dice en España, en general va a oír lo contrario. Y no me estoy refiriendo a la época de crisis, sino incluso antes, y también ahora que ya está remontando el gasto, que lo que más se oye es que tenemos un gasto demasiado bajo sobre el Producto Interior Bruto, que si nos comparamos con otros países deberíamos subirlo. Entonces yo aquí veo que hay una divergencia, ¿no? Ha opinado que lo estamos haciendo muy bien porque estamos controlando los costes, pero si oímos en general la prensa y desde luego si oímos a los proveedores, a la industria farmacéutica, a los médicos, a los sindicatos, todos están exigiendo que aumente el gasto sobre el Producto Interior Bruto. ¿Qué opina de esta discordancia? Y una segunda pregunta sería también muy en general. En España podríamos decir, simplificando mucho las cosas, que hemos ido de algunas fórmulas de capitación más o menos extendidas más hacia fórmulas más salariales. Si miramos hace años había más capitación que hay ahora. Y ahora hay más fórmulas estrictamente salariales. Entonces, ¿qué le parecería esta evolución que estoy simplificando un poco en exceso?
Let me answer the second one first, because I'm not sure I understood your statement. I believe Spain is currently relatively more on the salary side,
yes.
But I don't know that you've made a lot of progress towards capitation. It's maybe discussion, but I don't think that's a reality yet. That's
my point is that years ago, particularly in primary care, there was some form of capitation.
Okay.
And also we have had more recently in more particular settings in public-private initiatives, some forms of capitation.
Okay.
So the general picture would be, of course, there is a lot of discussion, but the general picture would be, as you say,
I see.
we now have salaries.
Okay.
But at some time, and in some settings, we had some forms of capitation.
Okay. I do not know about your history of how other forms have run. I'm still trying to figure out your current status. And I think that one comment is just the information needs of capitation are much more demanding. But the United Kingdom and Australia and many countries who have publicly funded single-payer systems similar to Spain have found it useful to move somewhat away from salaries. So that's my main point there. But it can still be salaries with other kinds of incentives. That's also very good. Now, going back to your other question about who is talking about costs being too high. In every country in the world, everybody thinks costs are too high. And it matters somewhat whether you're listening to the Ministry of Finance, who always thinks they're too high, or listening to the Ministry of Health and the doctors in the hospital, who are always saying, no, we need more. We need more money. And because of the separation of payment, I think consumers are often not aware how much of their taxes are going to medical care and health care. All they know is, well, did I have to wait for my elective procedures? How much demand for supplementary insurance do I have? Those are what are salient to the consumers, as well as a dissatisfaction about taxes. But it's true that many different groups have different views reflecting their own interests. And of course, doctors and unions and people receiving money from the public health system would like to have more. There's no surprise there. That's true in every single country. It's a question of where are the worst gaps and needs, and I don't have any information on that.
Bueno, pues yo creo que podemos terminar la sesión con estas respuestas y le doy nuevamente las gracias al profesor Ellis, a Manuel también por su presentación y a todos los que habéis asistido y habéis formulado preguntas, y también a Funcas por haber hecho posible esta sesión. Yo creo que podemos despedir al profesor Ellis con un fuerte aplauso.
Thank you. Thank you. Oh, yes, of course. Of course.